About Dupuytren's contracture. The reason for the talk, basically, over the past number of years, Dr. Gessler historically would do a surgery for this condition. Before that, Dr. Schuster would do the injections for this condition, but since, as we all know, neither of them work here anymore, we decided that it would be a good idea to bring back a treatment for this condition. So we are going to start doing the injections again like Dr. Schuster used to. But we'll talk about the condition and what's involved and answer any questions you have. So from a historical overview, basically it's progressive. You get bands or cords in your palm. It typically affects people of Northern European descent. So Viking disease is another word for it. So people that know their ancestry, it's more common in that group of people. Back in 1831, Dr. Dupuytren most likely came up with this as he discovered it and named it after himself. So basically it affects the fascia, which is the tissue just underneath your skin. So it really doesn't involve the flexor tendons, it involves the tissue over the flexor tendon, which can actually then contract your finger down into your palm. So it shows the layers of the skin, then the fascia, which is the tissue just underneath the skin. So the top slide is the normal, the bottom slide shows the Dupuytren's. Excess collagen buildup. So once again, it can affect people of all races, more common in Caucasians, Northern European descent, men more common than women, people after 40, although it can be all the way down into your 20s, although that's fairly uncommon. What causes it, like many things that we see and treat, nobody really knows the cause. There are some genetic risk factors. It can run in your family. There are certain things that make you more prone to it, such as excess alcohol consumption, diabetes, and smoking. So stop those things. And it can progress with time. So this is a photo of what it looks like. It shows the joints that can be involved. Your PIP joint, which is the first kind of knuckle joint. Your MP joint can be involved, but typically, once again, it's that band of tissue running down into your palm that's the problem that will then contract your finger down. And you can, not only with the cord, you get the nodules or little bumps there that are part of the disease process. Often this really isn't a painful condition. It might be a little tender, but pain isn't usually the problem. The problem is it contracts your finger down and you can't straighten your finger out. And you can get some pitting of the skin with it as well. And then this talks about the contracture or bending the finger down towards the palm. If it's a very mild process, we typically just kind of keep an eye on it. But if it gets to the point where their finger's bending down and they can't put their finger flat on the table, that's when we start thinking about treatment options. It can be very severe. Can actually flex your finger down into your palm so much that we almost can't even get a needle down in there to inject it. Hopefully most people come in before it gets that severe. So once again, showing obviously it's the palm side that's affected. You get a rope-like cord and your finger gets pulled down. And that's once again the tabletop test where you can't get your hand flat on the table because of the contraction. So because of that, these things can be affected. Obviously, if you can't straighten out your finger, especially if it really contracts down, it can adversely affect many of the things that you do throughout the day. So basically, if their finger is completely straight and they have a painless cord or a painless nodule, we don't recommend treatment. But if their finger's starting to flex down, and if it's bothering them enough they want something done, that's when we talk about the injections. Obviously, the more contracted it is, the more they have trouble dealing with it. And once again, the treatment really doesn't cure the disease. The treatment basically just breaks up that scar tissue to try to get the finger straight again. And even if surgically they have the scar tissue removed, it doesn't really cure the disease. It's just a treatment for the disease, and unfortunately, it could come back. I'll tell you what happens in the video. How's that? Rather than watching a 30-minute video. Basically, first of all, we have to get the patient pre-certified. So this isn't something we can see them and do the same day. So we see the patient in the office, examine them. Typically, there's no need for an x-ray. They might bring an x-ray in, which is fine. Typically, it's not any radiographic findings to speak of. Once we get that done, we have the patient come in, we get the medicine delivered to whatever office we're going to do it. You do have to mix the medicine together and then inject it. We can do 1 or 2 fingers at a time. Basically, we take a very small needle and carefully just inject through the skin. The goal is not to get down into the tendon, but just get through the skin into that fascial cord, and we inject it. Then we let the patient go home, and we see them back 24 to 48 hours later, typically. Basically, what we inject is called a collagenase, which basically eats up collagen. We bring them back to the office, then we numb up their finger with a local anesthetic. To do the injection, you don't need to numb it because it's just a small needle and a small injection. But the next part, which is the fun part, we numb it because basically we have to force their finger out straight, which typically hasn't been straight in months or possibly years. And with that, you feel and hear the tissue grinding and tearing. And if their skin is contracted down, which is often the case in a severe case, you actually rip their skin as you straighten it out. So often there are skin tears as well, which we just let heal. And we warn them ahead of time, your skin very well. That's what I was hoping to show you some nice gross stuff at lunch. But the video didn't work. So we numb it, we straighten their finger out, kind of 1 knuckle at a time, get it straight, put a soft tissue bandage on if it needs one, and then have them do some therapy with that. Once again, we can do, I think, up to 2 fingers at a time. So if there's more than that involved, we might do it in different settings. But that's kind of the nuts and bolts of what we do. And this is done instead of the major surgery where they make an incision, basically the whole length of your palm, to cut out the scar tissue. So this is done instead of the surgery. Question?
What's the difference between a trigger finger and this?
That's a great question. A trigger finger is basically a problem with the sheath over the flexor tendon. Typically, the pain is at the base of the finger only, and typically there's not necessarily a palpable cord or nodule in the hand. Typically, it's very tender, kind of at the base of the finger, and your finger catches down. We can take it and unlock it, and then it's completely normal till it locks again. Where this is a permanent contracture that's stuck that way. And no matter kind of how hard you push, it's still stuck that way. With the trigger finger, it kind of all at once catches down, and then it all at once unlocks. You can have both this and a trigger finger, and we try to figure out which one it is that's really bothering them. The treatment for a trigger finger can be a cortisone injection, ice. If it's bad enough, we do surgery to go in and release the tight covering over the flexor tendon. So that pathology, that problem is deeper down than this. This is more superficial. This is just, once again, the tissue basically right underneath the skin. Trigger finger is the A1 pulley right over your flexor tendon. Another question. Very good.
I might miss if you went over this, but after you do the manipulation
Yes.
and you release those adhesions, do you split the patient for a short period of time to make sure that it's
I think you
not
can for comfort, but I don't think you have to. Because typically once it's ripped apart, it's kind of ripped apart, and hopefully it's going to stay that way. I think it's more you gently have them move it so they don't get too stiff.
Is it one injection?
You can inject the tendon in multiple areas with small amounts.
Do they need to come for therapy?
They can come for therapy afterwards, yes. After the second procedure.
Are they encouraged to obviously
Yes.
stretch it,
Yes.
use it, and use it?
Yes. Another question.
Is this something typically, I know that everybody's different, but that would come on gradually, or you would just wake up and you wouldn't be able to open your?
It comes on very slowly. gradually. Yes. Often they say, my hand kind of looked weird for a number of years. I always kind of felt like a cord or something, and now I can't straighten out my finger. And if it goes untreated, typically their fingers slowly draw down more and more and more. Where with the trigger finger, it kind of snaps back and forth. Although occasionally we'll see a trigger finger that's been caught down for weeks, not very often, but occasionally the person will come in and say, gee, it caught down like this. And if, their skin should look normal if it's a trigger finger. You shouldn't feel a cord or a band, and that's another way to tell the difference. I like all the questions, thank you. She's pointing.
So, like for Uflexa, when you have to pre-cert that, because that's always a series of 3. So when you pre-cert that for Xiaflex, do you have to pre-cert that for so many injection visits? Does that make
No,
sense?
it's just, once again, if it's just 1 or 2 fingers involved, we can do all that in 1 injection.
Okay.
The second time they come back, we just numb it so it doesn't hurt as bad to straighten out their finger. But we're not injecting more Xiaflex the second visit. The second visit's just to numb them so we can pull them out straight. And then if there are any fingers involved, that's the end of it.
Gotcha.
Yes.
If you do notice it, like the mild thing, is there something you can do before letting it get to this point? Like, can you stretch it yourself before it's miserable?
Nothing's really proven to stop its onset once you can't change your ancestry. Now, if you're an alcoholic, obviously if you drink less, that's probably good. If you're a smoker, if you can cut back on smoking, that might diminish its progression. And if you're diabetic, probably controlling your blood sugars better might help. But otherwise, even cortisone shots haven't been proven to change the progression of the disease.